Okay, it's all yours, Mike.
Thank you, Sneha. So basically, I wanted to use today to kind of talk about tools, pain management tools, and that maybe my hope would be that you could add to your arsenal of working with people, having an idea of other kinds of things to do besides what you guys just traditionally do in each of your professions. So, and part of that is to also utilize tools to help reinforce kind of a collaborative relationship, sending the message that it's not just your responsibility to fix and cure them, that there are some things and some tools that they could use to help kind of cope and manage the pain on their own, making them more independent. Because as we've learned with persistent pain patients, there's not really an immediate fix or cure. So we need to form kind of a collaborative relationship where they take some responsibility. And my hope was in sharing some of these tool ideas that you can kind of subtly see where we're kind of turning this back to them, because it's about their life and their pain situation, teaching them some skills. Okay, next slide, thank you. So I wanted to use this as an opportunity to reinforce I love the model that Dr. Patterson uses with his, the 5 things that he does in working with. I think it's a nice heuristic device, a nice teaching method. So I wanted to reinforce this idea that, you know, when we work with people with pain, there may be 4 kind of pillars. The next slide, Sneha. And those 4 are basically education, you know, information, actual attempts to try to get some pain relief, physical rehab, which I think is a cornerstone to it. We need to get people up and moving. And then psychological interventions, taking a look at, we were talking about black and white thinking and also the involvement other people play in maintaining kind of the pain problem. Next slide. So next slide. Here are some of the tools. So in the next remaining 20 minutes or so, I wanted to talk about what I call the pain map, which is a kind of a map that shows us maybe some directions that we need to go, how to get where we want to get and where we've been. I wanted to talk about a pain flare-up record and how that may be useful in helping people begin to look at their pain, not just as a universal massive thing, but as a series of flare-ups, which could ultimately be more manageable and treatable. I wanted to also share with you a discovery journal, getting people to kind of journal about their pain with the goal of helping them begin to get some insight into factors that may be exacerbating or maintaining their pain problem, and ideally what they could do to kind of manage their pain better. Talk a little bit about pacing and got some ideas and models on that. I've got a slide on pain intensity categories, you know, the notion there that based on where your pain is, we may have a sampling of different coping strategies. In other words, you wouldn't use a certain type of coping strategy if your pain was minimal versus if it was in the severe category. So again, helping them, empower them to see that they may have some choices in what to do. Wanted to also maybe just talk briefly about some self-defeating ideas that I've seen. One of my favorites is the healing times chart. And then I end with a great little paper that was presented by a colleague of mine, approaches on how to deal with challenging patients and ideas on what to say. Any of these things that I'm going to talk about today, I'd be happy to send to you. Just give me your email and I can give you kind of the models that make it easy for you to then just print them off and utilize them with your patient. Okay, next slide. Next slide. So here's the healing times data. I love this, and this is very messy, I apologize, but I just wanted to give you an overview of how you could take a look at different types of injuries and what the typical usual healing times could be. Now, again, this isn't black and white, it's just a guideline. And I have found it useful with helping people who have persistent, just like the case I presented, the idea that, you know, 2-3 years after an injury, this guy's still worrying about healing, his ribs healing, when in fact, you know, we could take a look here and go, hey, the healing process probably stopped quite a while ago. There may be other factors that are perpetuating your pain that we need to look at, but it's not about time. I need more time to heal. I hear that all the time. So that's the first one. And the next slide shows you, thank you, shows you again, different, it's one big document that I have, and that's the second part of it. And, look at a herniated disc, operative, I guess, post-surgically, it's just several months. I've often was told that the more dense the material or the substance, the longer the healing. So soft tissue muscles heal much quicker than bone. And I've been told that, and hopefully that's accurate. So I think these numbers reflect that in terms of the healing time. Next slide. And if any of you, let me go back to that. You don't need to go back to the last slide, but I have citations for all of that in the medical literature. So if you're interested in, who made this, I've got that data for us too. So here was that one slide I was talking about coping strategies. The idea here is that sometimes we can use different strategies based on the intensity of our pain. And what I liked about this slide is just it offers some ideas that, hey, there are different things to maybe do at different points in your pain intensity, including with low pain, just work within a safe tolerance, continue to keep moving with some statements there. So, pain is not just one thing, one giant thing. It's a series of levels of intensity that may have some value in looking at it that way in terms of what coping strategies to use. Next slide. Okay, pain map, next slide. So I created this number of years ago, and I found it useful, and I hope it could be of use to you guys. So what this is intended to be given to your patient, and with a clipboard and a pen. And you basically ask the person to start filling this thing out. So one of the first questions is say, hey, what is my diagnosis? What have you heard I say is wrong? What is your pain generator? Frequently, of course, the doctors have told them a number of times what it is they believe, but you'd be amazed how many patients can't remember what it is their diagnosis is. So here's an opportunity, if they don't know what it is, to have them put it down. In that same box, we asked, what do you think is physically wrong with you? And this is a discovery exploration, because frequently it may not be what the diagnosis is. It may be something very different. And of course, in the worst case scenario, it's something catastrophic. Like, my cousin Louis had the same problem I have, and he died of cancer. He had a tumor. And, that's what they're really worried that they have. Well, that can kind of be a nice stimulus for some conversation. And it may be, totally inaccurate compared to your diagnosis. So you get them thinking about that idea of what is wrong with me? What is my pain generator, and how accurate is it? And I go back to my early training with Dr. Richard Cronin from UCLA, and he always said, if you don't have a diagnosis, you don't have a prognosis. So it's an important starting point, I think, in working with your pain patients. What is wrong with them? What is your pain generator? So then, just kind of going from the top around like a clock, what medical treatments are recommended? Do we do injections? Do we do trigger points? What do we do? Add that the physical therapy component, which is another one of the major pillars. Get people moving. Have they gotten deconditioned, out of shape? And then we talk a little bit about avoidance behaviors. Some avoidance is appropriate, but my experience has been most pain patients avoid too much, and then they lunge on the couch, and we begin with the deconditioning syndrome. So physical therapy is an important point, and I'll move through this quickly. Medications. My favorite question for anybody using opiate meds is, is your quality of life at an acceptable level with these meds or not? And are they able to function? Do these meds help you increase activities? If I get no's to those two questions, then I think we need to entertain a conversation with the medical doctor regarding how useful they really are. And instead of going up, maybe going down is the answer. Sleep, huge issue with people with pain. I want them to look at how their sleep is. Is there a possibility of really lousy sleep hygiene? Are they on the couch watching TV with the dog with them all night long? There's some simple things that can be done to address poor sleep hygiene. And of course, we've got obstructive sleep apnea. When you put on weight because you're not active, that may add adipose tissue to your throat and create a greater likelihood for some obstructive sleep apnea. And we know that opiates can affect central sleep apnea. So it's a very important area, in my opinion, to map out and to take a look at. For my people that I see, oftentimes they're not working. And what are their goals and what's their realistic expectations there? That often can become a motivator, like I used with the case I presented. What can you do despite having your pain? And does it match with what you've made as a living? Do you need to find something else? And oftentimes that stimulates people to start thinking about their future, and it distracts them from their current focus on their pain. So, are they off work? And if so, what are their long-term goals? The next area, circumstances of pain, huge. We talk about blame, injustice, fault, trauma. I would invite all of you to ask the person, how did they get hurt? How did this pain problem start? That could be a major obstacle for their recovery. If it is blame, injustice, fault, the employer didn't, do the proper training or whatnot, that's going to be an obstacle for their recovery. And until we address that in some way, I think it would impede many people from getting better. I have current coping strategies and just a plus and a minus. What are they doing? Is it working? Is it not working? And what other things could they do? Moving around the circle, as a psychologist, it's fascinating to see personality types. And while we've never come up with a DSM-5 axis 2 personality disorder called chronic pain, there are certain traits that are challenging and potentially problematic when we have a persistent pain signal. And that's, the perfectionism. I'm not done with this case, this claim, until I'm 100% the way I was before the injury, is an example of that all or nothing kind of black and white thinking tied to it. And some people exhibit more of that than others. Smoking, alcohol, caffeine, huge substance issues that can impact pain. My case in point that I did today is an example of both alcohol and nicotine and its role in exacerbating and maintaining this guy's pain problem. ACE, adverse childhood episodes, events, past history, trauma. It's very common in my profession, since I have time to work with people, much more than the minutes that many of the physicians, you guys out there medically have. When you ask people about their past, it's very troubling. They haven't been nurtured. They've had previous assaults. All of those issues kind of lead to a sense of invalidation. And a pain problem can also be invalidating if they feel like they're not being heard, which then kind of leads me to the mood issues. How depressed are they? How anxious and fearful of re-injury are they? And of those three, depression, anxiety, and anger, interestingly enough, my experience has been anger is the number one mood. And that may be because I'm in the workers' comp arena, and there's a lot of good reasons to be frustrated and angry, I think, as people like you, Dr. Patterson, know. So this is the pain map. And my idea here is that if you give this to the patient and let them circle some of these things, or, not that you need to talk about their past trauma, but just to be able for them to start looking at, hey, it's not just about you, the doctor, fixing me and taking the herniation out of my disc as the end all to dealing with my pain problem. All these other factors can play a role, and they, as the patient or the person with pain, play a major role in what happens with those. Next slide. Flare-up record. Next slide. So I found this to be very helpful. I give a copy of this to several copies of this between visits. And my notion is that a lot of people in pain believe that it's continuous, it's constant, it's always there, and it's terrible and awful. when you get them to do a flare-up record, they begin to see that, well, wait a minute, there are periods of time when it is not as bad. And I think that's a very important, subtle kind of thing to teach them, that it's not all or nothing, just one thing. It's not a 10, 24/7, 7 days a week. And this little form helps them kind of recognize that. It also ties in, if they fill this out, how mood can play a role in their pain. When they have several flare-up records and they begin to see that, boy, my anxiety fear score 0 to 10 is always a 10. When my pain is up, hey, maybe anxiety is playing a role in that. So I have 3 categories utilizing the biopsychosocial model. This first one here, I couldn't get it all on one page for the slide, but you see, I would invite them to circle, what are the biological physical triggers? Maybe they go, oh my God, you know what? My body mechanics is terrible. I lifted that thing and I didn't move it in the right way. Or, the weather's changing and I didn't sleep well the night before. And my posture isn't good. So they begin to see the role that physical and biological factors that they may have some control over play a role. Next slide. So the next 2 are, psychological triggers, ideas and thoughts. What were you thinking? And it's amazing. These are pretty common thoughts. So I just have them circle it. I shouldn't let the pain bother me, or, I need more medications. This is awful. People think and say these things. So if they tie those thoughts to the flare up, they may begin to see that there could be an association here with their thinking and their flare up. End it with social triggers. Have others played a role in this flare up? Did they ask you to do too much? Did you feel others aren't helping you enough? So that kind of ties into, in my case that I presented, the role that the wife played. Then you end with, hey, what did I do before the flare up? What did I do during, and what did I do after? The idea here is that you begin to get them to see it in a context of many things. And again, I think it's been empowering for a lot of people and an eye opener when they fill these flare outs for, you don't have to do it for a couple of days. They begin to see the patterns. Next slide. Kind of based on the same idea. Next slide. I've got what I call the discovery journal. These I've got like 20 days. This is day 1. And it gives them kind of an inspirational quote, a food for thought. What is the goal for the day? Give me your pain ratings morning, afternoon, and night. Again, we tie in anger issues, mood issues, energy levels. And then I look at sleep. How was the previous night's sleep? To begin to see if we have any connection with that. So there's a series of a bunch of these that I find helpful. And if people fill these out, if nothing else, you're getting them to do some homework and to realize that they, can maybe play a role in their recovery and rehab. Next slide. Next one. Thank you, Sneha. So, pacing, huge issue with people with pain. And to sum it up, the classic case that I see is someone is down because their pain's up and they've laid on the couch for a day, 2 days, and now they're really pissed off, angry, and tired at the pain doing this to them. And they say, screw it. The next day they get up and they go, I'm going to mow the lawn. And they go out and they kill themselves. They take an extra pain pill, get the lawn mowed. That feels good. But at the end of that day, they're falling back into bed exhausted and their pain is major flared up and they're down for 3 days. And we get this pattern of up and down, up and down. So talking about activity pacing is very critical. And my other analogy is an airplane. When it wants to take off from the airplane doesn't start off and go straight up like a rocket ship. I said, if it did, what would happen? It would come straight down and crash. So we need this, over the tarmac, we need time to gradually take off. Pacing's the same thing. We can't do too much too soon. So I like to emphasize that concept. Next slide. Next slide. So here was a paper put out by a colleague of mine, and I can get the reference. And this is terrible slide, I know, but I wanted to just give you an overview. If people are fixated on pain on the far left, here's some ideas on what you could maybe use or say. If someone on the other end is showing an increased use of medications, here are some comments you could use to respond to that. And the last slide, if you look at it, next slide, is just a little screenshot of, you know, what that looks like. And I'd be happy to send you a copy of a more readable version of all of this. And in this case, you know, what are you doing to manage your pain on a day-to-day basis, in addition to taking the medications? Get them involved. And so I found there were some pretty helpful comments that could be useful to you in your day-to-day practice. So to sum up, the whole idea here is that there are tools, additional tools that are out there that we know work, and you don't have to just have a prescription pad, a needle and a syringe and some drugs to deal with this. You can help train your persistent pain patient into doing things for themselves. So I know we're a little bit short of time, but that's good. Any questions? And as you can see here, October 6th is our next topic, recognizing, diagnosing, and treating popular drugs.
Any questions? Thank you, Mike.
Oh, really well done. Thank you.